So I've been asked to discuss how to optimize renal replacement therapy, and it's a nice follow-up from Olivier's presentation. So can I have the next slide? Yes, so I've got a few disclosures that I need to make. Next slide, please. Sorry, can I have the, yes, okay. So renal replacement therapy is a widely used therapy to support the patients throughout the world. And when you talk about optimizing, you need to discuss what are the quality indicators, and there are no widely recognized quality indicators available. There's to make the things even more complicated, you know, there is wide variations of practice across centers. Some centers use intermittent, some use continuous therapies. There are different modalities, different levels of experience. Next slide. Schoenbach and his colleagues once again have proposed some quality indicators. Next, there are some animations, please. And these animations, I try to summarize them into 5 elements: the way to maximize the delivered dose, the way to enable fluid balance, to optimize and stabilize the therapy, and optimize the prescription. Next slide. So I'll try to make this into modifiable factors. So essentially, if you move from objectives to the modifiable factors, there's 4 elements of care, and that we will focus on for the rest of this presentation. Next slide, please. The first and of uppermost importance is the catheter. It's the vascular access, the way to start the therapy. Of course, without an adequate vascular access, you will not be able to deliver any form of therapy. Next slide. So to the vascular access, the best vascular access needs a few definitions that are presented here. You need the right design, and it's depicted on the image that's on the right. It's called kidney shape, so it's the shape that will minimize the turbulences, and therefore the propensity of the blood to clot within the catheter itself. The right lumen, the right tip, the shotgun tip as shown on the picture, the right length, and here you really have to ascertain that the tip of the catheter is positioned in a wide vein, a large vein, a central vein with a sufficient flow around the tip of the catheter, the right material. Today, the best material appears to be silicone, is the most biocompatible. This might change over the time. The right diameter, very important, as you know, Poisson law. The flow is proportional. It's proportional to the diameter of the diameter of the catheter, and you at least want a catheter that's 12 French to be able to have a sufficient flow. And then the right site. And this is the work from Caen, Perienti, and colleague that showed that the preference, there was no limitation in terms of infectious disease to as per the right IJ versus the femoral line, and except for the obese patients, and so preferably the right internal jugular, and second, the femoral line. But most importantly, and I think the message here, you need the right catheter, but you need to be aware that there might be issues with the catheter, and if there's something wrong, be quick to replace the catheter if there's an access pressure. Next slide. So identifying access pressure, this is what we'll focus on the next 2 slides, is next slide. Is the main thing, because if you have the catheter issues and vascular access issues are half the reasons why you might run into problem with your circuit. So the first thing is to think about catheter issues. It is going to be the problem in half the situations. Next slide. So here you need to look at the pressures on your circuit. The catheter pressures are the arterial pressure, which is normally a negative pressure. And if it's much more negative than it's supposed to be, it's very likely that you're actually struggling to aspirate. The machine actually is struggling to aspirate the blood from the patient, and this is most likely a problem of the catheter. The second one, although much more specific, is the venous pressure, which can increase. And when the association of low, very negative arterial pressure and very high venous pressure occur, it's suggesting that there is a catheter pressure until otherwise proven. Next slide. So you can do a few things to try and fix the catheter. You can try and rotate, because as you've seen, there's some lumens on one side. So if you rotate the catheter 180 degrees or sometimes 90 degrees, you might access an area of higher flow. You might rinse the access slide. Then there's things you can do depending on the modality you're using. And one that is often performed is to simply decrease the blood flow. But of course, if you run the therapy in continuous veno-veno hemofiltration, you might run into issues with filtration fraction. A problem will get back together. Then if you think your patient is hypovolemic, you might consider administering a fluid bolus. If the patient is agitated and kinking his catheter, maybe you need to increase the sedation. But in any case, please do not try to switch line. This is the easy answer that is commonly performed overnight to just keep the circuit patent. It really decreases the quality of the dialysis. It might risk also to send some little clots to the patient's lung. So this is not something that we should encourage on a practical, on a day-to-day basis. So think about all these things, and if not, replace the catheter swiftly. Next slide, please. So we've discussed the catheter. The next bundle of elements to discuss is the anticoagulation. Next slide. And here, it's quite easy to go forward, because there's for once a clear response and a clear literature supporting the use of regional citrate anticoagulation, which nowadays should be the default anticoagulation regimen for at least continuous renal replacement therapy. Here, I'm showing some data obtained in my center, and this is real-life data. It's not a randomized control study, but it's a reasonably large number of circuits that we retrospectively looked, and this is the filter life. The red line is the filter life of those circuit ran in CVVH mode with heparin anticoagulation, and the blue line is those circuit ran in CVHD mode with citrate anticoagulation. And of course, it's not randomized. There's a selection bias. It's not the same patients, and it's not the same mode. We'll get back to the importance of this a bit later. But please note of the magnitude of the difference: 15 hours versus 55 hours. And again, this is real life, close to 4 times the duration, the circuit lifetime duration. And then on the right side of the slide, you see that the KDIGO Society, the international recommendations, have already been suggesting us to use citrate anticoagulation for already many years. Next slide. And very recently, we had the confirmation of this superiority in a randomized control trial. There had been already other smaller randomized control trials that also suggested a much higher filter lifetime with citrate anticoagulation. Here, this is a large, multi-center German trial, and here the superiority of citrate was confirmed in terms of filter lifespan, more than 15 hours mean difference. And the study was also looking at mortality as a co-primary outcome. There was no difference in this co-primary outcome, but mortality is probably not the main thing. You don't want to save the patient with the dialysis, but in terms of optimization, the filter life is much longer with citrate. Next slide, please. So is it time to move to citrate? The short answer is yes, but we're all living now a pandemic, and it's probably not the right time to move and to change such a therapy. So if you're currently using citrate and happy with that, well, there is margin for improvements. As soon as the situation gets back to normal in your area and your unit, probably consider implementing. Why do I say that? It's because citrate, it's not just a switch on a button. It's a modality that needs to be, for which the team needs to be trained. You need to be familiar with the potential complications, with the issues that might occur and how to deal with them. So you need to have your team focused on this, and it probably cannot be in a period like the one we're living now. But as soon as things go back to normal, which I hope it's going to be as soon as possible, of course, then probably consider moving to citrate if you haven't already. Next slide. So coagulation problems, again, will be very rare in the setting of citrate anticoagulation, but still can happen. And here you'll be looking at some also pressure problems when there's coagulation. The most specific is probably the pre-filter pressure and also the venous pressure, which would increase when there is a coagulation in the filter or the second part of the circuit. Next slide, please. And what can you do? So here it depends on the coagulation strategy you're using. Of course, if you're using heparin anticoagulation, you want to make sure that you're actually delivering sufficient heparin to your circuit and to your patient. The blood is actually anticoagulated, so monitor the PTT, the anti-10A activity. But usually this is not so much the problem. The problem is usually interruptions. You're giving heparin, but probably you're stopping the heparin because you want to go back to theater, because you want to do a lumbar puncture, because of all different reasons. The patient is bleeding, and all this time that the anticoagulation is insufficient is when the single membranes are clotting. So optimize the time during which the heparin is administered. Otherwise, and if you do CVVH, you can increase the blood flow to optimize the filtration fraction. Again, we'll get back to that. This will decrease the concentration of the blood if there's more blood to enter the circuit. You might also want to increase the pre-dilution. Pre-dilution can help. Of course, this is the purpose of pre-dilution, is to help keeping the filter patent. Unfortunately, of course, and we'll get back to that again, it comes at the cost of decreased clearance. If you do citrate anticoagulation, then the risk and the problems that you will run in terms of coagulation will be much rarer. Of course, you want to also check that if you don't do on a routinely basis, that the calcium, the ionized calcium within the circuit is within the target range, that is under 0.4 millimoles per liter. And if you still have problems, particularly, and if it's generalized to all your patients, you might have a problem with the calibration of your arterial blood gas machine. As it's been shown recently, there are some different calibration, and those machines are mostly done to calibrated to measure calcium in the normal range, which is about 1 to 1.2 millimoles per liter. And when your machine might not be adequate for the range of 0.3, 0.25, so this might be something you need to consider. And last, if you still run into problems, your patient might have heparin-induced thrombopenia, which is one, it's of course rare, but it's one of the typical cause of recurrent clotting in citrate anticoagulation. Next slide. Okay, so we've considered catheter, anticoagulation, and then I'm going to discuss modality, renal replacement modality. Next slide, please. So I like to present the two main modalities, and so far I've mostly discussed continuous renal replacement therapy. But of course, renal replacement therapy can also be applied in the intermittent form, intermittent hemodialysis. And I like to compare these to present this modality as like a Formula One. It's a super powerful way of clearing the blood, and you only have to apply this method for a few hours per week, 3-4 hours, 2 or 3 times a week, and this is sufficient to maintain your patient's blood composition within the normal range. And of course, this is what's been done for outpatients. In the ICU and in many ICU throughout the world, continuous modalities are preferred. Of course, they have much lower clearance, but it is applied on an almost 24 hours basis. Next slide. And historically, these two modalities have been opposed, and there's been numerous trials, mostly in the early 2000s, trying to compare early intermittent versus continuous therapies and trying to demonstrate an impact on mortality. So there's no benefit in any modality in terms of mortality. Once again, unfortunately, perhaps, but there's no difference. Next slide. And there are some data to which I contributed, were suggesting that renal. Next slide, please. There are some data suggesting that perhaps continuous modality could be associated with improved renal recovery. However, these data are largely relying on observational data, and again, the randomized control trial have never really shown more than a trend for benefit for continuous renal replacement therapy. Next slide. So I think today, and particularly in a period of hardship like the one we're living now, I think we're not in this period where we should fight and try, and we should rather consider the pros and cons of both modalities. And I try to summarize them on this slide. Indeed, intermittent and continuous have separated indications, I believe. And in some patients, you might want to use one. In others, you might use both. You might, sorry, the other one. There is a rationale for some situation. Next slide. So this is pretty much what the French Anesthesiology Society recommends, to combine these modalities according to the availability and experience of the team. Next slide. And maybe optimization here is combination, and combining modality is probably the way to go, provided you can do both. And most units can do both, because we always transition the patient that survived to intermittent dialysis. Next slide. You can roll on with the animation. So in the setting of acute kidney injury, I would suggest probably that in most patients, you would be more comfortable starting with continuous renal replacement therapy. It's more it's better tolerated, it's easier, you can combine it with other therapies. It's more, it's better to focus, to control the fluids. And then transition early to intermittent modality. So what is early depends on your experience, depends on everything. And some patient early might be immediately. Perhaps if you have a COPD patient coming to the ICU for something completely stable, then you might, and it needs RT, you might start straight away with intermittent. So this transition might be calibrated depending on your experience in your center. Next slide, please. Then in terms of CRT modality, there's of course a choice of hemofiltration, hemodialysis, hemodiafiltrations, and you know that all current generation machines can do all this, all new filters that can do this. And there's no, to be honest, data that really demonstrated the benefit of one or the other modality over the others. So next slide. Again, there is no data, but I will tell you in a few slides why CVVHD is my preferred modality and the one I think that should be increasingly utilized nowadays. Next slide. So the trouble, so I will mostly compare hemodialysis with hemofiltration, and then for those hemodiafiltration user, just be in the middle. You're the Swiss here, and you're the compromised people. But CVVH has the main issue its main issue is related to filtration fraction. Of course, you're doing ultrafiltration. That means you're removing fluid, and by doing this, you are concentrating the blood. And of course, the more you concentrate the blood, the more likely the blood is likely to clot. So you know the filtration fraction, you need to calculate it, you need to monitor that, you need to keep it under 20% to minimize coagulation. And this implies, as a very, very, very short shortcut, the highest possible blood flow. And you know you're going to have to run the blood flow above 250 mils per minute to be comfortable with CVVH. Next slide. CVVHD mode, you don't have to worry about the blood flow. The blood flow is not the limiting factor. You reach a clearance that is adequate as long as you have at least 60 to 80 milliliters per minute. And the limiting factor is not the blood, it is the dialysate. So why is that important? Because a lower blood flow decreases the strain on the catheter. There's less dependence on a perfect catheter. There's less interruption, less need for replacing the circuit. You can deal with less patient with lesser volemia, intravascular volemia. So it's much easier because you don't have to drain so much blood per unit of time. Next slide. And this is suggested by this data from the team of Rinaldo Bellomo in Australia. And here, if you look, they compare CVVH with CVVHD in patients with no anticoagulation at all. And of course, the circuit lifetime is bad, much lower than what we've seen previously in the randomized control trial. But here, you can see that patients with CVVH circuits run in CVVHD mode had much longer filter life than those run in CVVH mode, irrespective of anticoagulation. Next slide. So there's less strain on the catheter, and the second benefit is because the blood flow is lower, and as you know, the citrate, which we've recommended to use a little bit before, the lower blood flow means lower need for citrate because the citrate is coupled to the blood flow. So less citrate means less risk of complication, and therefore you can use citrate for patients who you would be more or less comfortable to use them for. Next slide. So low blood flow, you can run the animation.
Please, Antoine, we have
I'm too long.
Yes.
Okay. So I'm going fast. So you don't need pre-dilution. You don't need pre-dilution. You can go to the next slide. I'm cut. I'm done. Okay. No. So I'm just gonna really quick. So just grow the animations. No need for pre-dilution because it's. Can I have the whole slide? Sorry. Anyway, so the point with CVVHD, the benefit is you have low blood flow, you don't need pre-dilution, and the clearance is excellent, at least for small molecules, which are the ones that we really care about. The middle molecules is a problem and is has less performance, but you can deal with that by changing the membranes. This is the last elements that I wanted to bring. You can choose the adequate membrane, you can choose the right size, and you can potentially increase the size of the pores and then compensate the deficit of clearance for higher molecules. So that brings me to my conclusions. I don't have my slides, but I can tell you the way to optimize renal replacement therapy is to have an adequate vascular access, adequate anticoagulation, which is citrate in most situations, combinations of intermittent and continuous modalities, preferred, but again, this is my opinion rather than evidence-based, diffusive-based, or at least diffusive, including modalities. And last, I would add your staff to adequately respond to your alarms. So sorry for the technical problems, and thank you very much.
Thank you very much, Antoine.